Our next presenter is Jordan Bird. He's a UBC PhD candidate that works with the MIPS Econ Lab. And I'd be happy to say he was our third Rising Star awardee. So congratulations to both of you. Go ahead. Thanks, Jordan.
Perfect. Thank you so much. I'm very honored to be here with you guys today. So hopefully there'll be some interesting things in this talk. So kind of following off of what Matthew and Sunny were saying, the definition of death in Canada is predicated on a permanent cessation of brain function. And this can occur from a cessation of blood circulation to the brain after circulatory arrest. How we actually look at this is with a pulse pressure of less than 5 that is generally done at the radial artery. And so with this, we make the assumption that what is happening at the radial artery is simultaneously happening within the brain. And so here, clinically, we're monitoring the arm. Does that actually mean what's happening in the brain? If you go back 250 years ago to Alexander Monro, he suggested that blood flow to the brain and blood flow to the periphery are not actually identical. And so here we're making them synonymous, but is that actually the case? And so that's what we sought to try and explore. So to do this, we used a methodology of both cerebrovascular and cardiovascular measurements through the dying process for our patients undergoing withdrawal of life-sustaining measures. And so for cerebrovascular measures, we used transcranial Doppler ultrasound to look at both the anterior and posterior parts of the brain from the middle and posterior cerebral artery blood flow velocities, along with jugular venous bulb oximetry to look at venous oxygen saturations as it's coming out of the brain, and near-infrared spectroscopy of like the frontal lobe. For whole body measures, we used Swan-Ganz catheters going down into the heart to look at pulmonary artery pressures, cardiac outputs, as well as mixed venous oxygen saturations. And then we also had ECG and radial arterial lines to look at MAP and pulse pressures. So what this looks like is here we have our patients were outfitted with this monitoring for continuous monitoring of cerebrovascular and cardiovascular measures throughout the dying process and through to death. And then we also took blood-based brain biomarkers prior to withdrawal of life-sustaining measures and partway through this process. And then we also have autopsies for anatomical correlates to try and understand what's happening within the human body. And so the first question that we have when we started this work a year and a half, 2 years ago was, is this actually feasible? Can we collect this data? And so with this here on the y-axis, we have 32 patients up to this point, and along the x-axis is each of the individual data points. And so through all these different measures, we actually have really good feasibility. Particularly note that with the ECG and the arterial line and cerebral blood flow velocities, we're actually collecting this in most, if not all cases. And so the takeaway from this is that simultaneous multimodal cerebrovascular and cardiovascular data collection is highly feasible during the data process. But when you're in the room, what does this look like? It is a lot of monitoring. There is a lot that goes into this process where we have a variety of monitors that come in really involved in this process. And then we get a whole bunch of signals both during the process, and we also retrospectively look at them afterwards. And so we're both looking at them in real time and after the fact to try and make some of our understanding of the dying process. So what actually happens with timing. So similar to like Matthew, we looked at the time from extubation, and so that's on the x-axis, and on the y-axis is our 32 patients. And here we have various thresholds. And so the threshold for the MCA and PCA are the cerebral blood flow velocities of the anterior and posterior circulations. And then mechanical asystole is that pulse pressure of 5 millimeters of mercury. And the thing to take away from this is that it is very heterogeneous. And so depending on the etiology in which patient, we have a whole ton of different time spans for when this is actually occurring. And so the timing of circulatory arrest after withdrawal of life-sustaining measures is heterogeneous. If we actually zoom in and look at the difference in time between when cerebral blood flow velocities cease and when we have mechanical asystole in gray or electrical asystole in blue, there's a huge discordance here where in all cases, we end up having the cessation of like brain blood flows occur prior to mechanical and electrical asystole. Notice in some of these cases, like TBI 15, who wanted to be an organ donor, that's over 30 minutes of extra time that they would not necessarily be able to donate their organs. And so this has like real world implications. And so the takeaway from this is the cerebral circulation is lost prior to the systemic circulation. But perfusion is just one side of the coin. Another side of the coin is what's happening with oxygen. And so like the diffusion side of things and what's happening potentially for function. And so for that, we used oxygen extraction fractions. And so to do this, we use simultaneous assessment with jugular venous bulb oximetry up into the brain to look at oxygen extractions within the brain, and then down into the heart so we could get whole body oxygen extraction fractions. With this, we could actually determine what's happening isolated within the brain for individual participants. And so generally, there was differences between the two groups, where this particularly comes out as you decrease mean arterial pressure. So as blood pressure starts to fall, the rest of the body is able to increase more oxygen to preserve function, hopefully, whereas the brain is basically a flat line, so not necessarily able to preserve function. In fact, when you look at it across the whole body, the brain extracts less oxygen in the whole body in pretty much all cases. And when we look at it on an individual basis, individual brain and systemic oxygen extraction fractions are not synonymous. And so with that, this suggests that the brain does not extract oxygen as well as other organs and should be considered separate. We can't necessarily use peripheral hemodynamics to inform what's happening in the brain. The next thing we looked at was, okay, well, what about a gasping reflex? And so this can occur during the dying process where an individual breathes in and you have an increase of blood to the thorax, into the heart, and then potentially cause an increase of blood to the brain. So with this here, we saw that with the gasping reflex, where on the x-axis, it's the time from the gasp, and then central venous pressures dipped transiently before increasing. And we saw an increase of blood pressure in the heart as we're increasing the amount of blood that comes back to the heart to be able to pump out through the rest of the body. And there does not seem to be too much of a change, and it's very transient within the middle cerebral artery, so not much getting to the front of the brain. However, when we look at the posterior part of the brain, blood flow to the back of the brain transiently increases and to a greater degree than MCA. And so you can't necessarily also assume that the front and the back of the brain are synonymous. So the takeaway from this is that the gasping during the dying process may facilitate some blood flow to the brainstem, but it is very transient and it's generally is gone within 10-15 seconds, and so not very permanent. One of the things that Sunny had also mentioned was how can we potentially predict who might be an organ donor? And so to look at some of that point of view, what we did was we took measures prior to withdrawal of life-sustaining measures, and does any of that relate to how long the dying process would be? So our thought process behind this was, okay, if the brain is what is central for death, perhaps we look at markers of brain injury and determine whether that can predict how long the dying process would be. So we used UCHL1, which is a marker of neuronal cell body injury, and that can get dumped into like the circulation that we can then detect with a point of care blood test. And we then related that from the time of withdrawal of life-sustaining measures to mechanical asystole. And there seems to be a relationship where if you have an elevated amount of this biomarker, it generally suggests potentially a shorter dying process. And this might be a way to stratify organ donation and help families with how long this process might actually take. In fact, it is pretty specific as a single independent variable. And we have hope that potentially we could take this towards a liver donation to understand when you might be able to get a liver. And so with this, a blood test may help us predict how long the dying process may take, with some implications for organ donation. So as a little bit of a recap of our work, we have implications for death and organ donation, where blood flow to the brain may cease prior to systemic circulations. Oxygen extraction fraction was lower pretty much in all cases across all of our patients. And so with that, perhaps function is giving out earlier than we previously assumed. Gasping during the dying process, as this is a process that does occur in a lot of cases, causes a transient but like not a very big increase in brain blood flow. And so that's something to consider for some of these cases moving forward. And the anterior and posterior parts of the brain are not necessarily synonymous. And so we can't necessarily use an individual point of the brain to inform what's happening globally. And then lastly, blood samples may help us inform how long the dying process may take. Moving forward, we have started doing some intraparenchymal neuromonitoring. And so this is direct measures of the brain to be able to determine what's happening with the hemodynamic status, and which we hope has like great implications for NRP, as well as looking to validate some blood samples for the prediction of like the dying process. And with that though, this work does not happen without a whole ton of people, a lot of patient family partners to help inform this work, and a lot of people really dedicating a lot of time. And so really wanted to acknowledge the team that we have at Vancouver General Hospital, because without them, none of this would be possible. And thank you very much.